Ask a nurse what they're most afraid of. Most won't say needle sticks or hostile patients or even burnout. They'll say harming a patient. That fear isn't irrational. It's the weight of the responsibility they carry every single shift. But what happens when that fear becomes real? When an error occurs, a patient is harmed, and a nurse is left to live with it? That has a name now. It's called second victim syndrome, and it's quietly driving good nurses out of the profession. The term comes from Dr. Albert Wu. In a landmark paper in 2000, he described what happens to clinicians involved in a medical error: guilt, shame, self doubt, and often a deep question of whether they belong in this profession at all. The patient is the first victim of the error. The clinician becomes the second. And the research is sobering. One recent study drew a straight line from that distress to turnover. The nurses hit hardest were the ones most likely to leave the profession. Another found that two-thirds of ICU nurses reported psychological distress after an adverse event. We're losing nurses, not just to burnout, not just to pay, but to the aftermath of the very errors they were undertrained to prevent. Most of the conversation about second victim syndrome focuses on what happens after the error: peer support, debriefs, assistant programs. Those matter. A nurse who's been through something traumatic deserves support, not silence and a write up. But we're not asking the harder question: why are the errors happening in the first place? And the answer, more often than we admit, isn't negligence. It's a gap between what nursing education produced and what practice actually demands. It's a nurse who graduated knowing what diseases look like, but not how body systems fail, who was never taught to anticipate deterioration before it announced itself, who passed NCLEX and walked into her very first shift without a reliable framework for the most consequential skill of her career: clinical judgment. Missed the early signs of sepsis, failed to escalate in time. That's a clinical judgment failure. And clinical judgment was never systematically taught. It was expected to develop through experience. For some nurses, it does. For others, the first time it fails, a patient is harmed and a nurse is broken. And here's what makes this so devastating: the guilt these nurses carry isn't proportionate to their intent. No nurse harmed a patient on purpose, but the weight lands as though she did. What is proportionate is the gap between the judgment she needed and the education she got. So, when she makes an error under those conditions, she doesn't think the system failed to prepare me. She thinks I failed the patient. That internalization is what drives second victim syndrome, and it's being multiplied across a profession already stretched past its limits. Yes, peer support is necessary, but it isn't sufficient. The real structural answer is preventing the errors that cause the trauma in the first place. And the most reliable way to do that is to change how we teach, to replace content delivery with clinical judgment development. That means teaching how body systems fail, not just what diseases look like. Building early recognition into the curriculum from the very first clinical course, using cases that demand reasoning, not recall, and teaching psychological safety. The willingness to escalate before you're certain is a clinical skill. When nurses graduate with a real clinical judgment framework, they catch more, they escalate earlier, they see the patient who is compensating before they decompensate and the alarms go off. We talk about the nursing shortage as a supply problem, a pay problem. Both are real, but part of this retention crisis is a preparation crisis in disguise. Nurses who feel chronically underprepared, who carry the weight of close calls they never had the tools to prevent, they leave, not all at once, and not always with a clear reason. They just stop being able to do it anymore. The fear of harming a patient is the right fear. It's the fear that makes nursing matter. What we owe nurses and the patients who depend on them is an education that prepares them for practice to recognize early and act on a patient becoming unstable. So let me leave you with this. Are your students being prepared to make the clinical judgments that prevent patient harm and protect their own future in this profession? If that's the work you care about, visit lifebeatsolutions.com. Thanks for watching.